Good afternoon. I'm Commander Ibad Khan, and I'm representing the Clinician Outreach and Communication Activity COCA with the Emergency Risk Communication Branch at the Centers for Disease Control and Prevention. I would like to welcome you to today's COCA Call, Outbreak of Lung Injury Associated with E-Cigarette Product Use or Vaping, Information for Clinicians. You may participate in today's presentation via webinar, or you may download the slides if you are unable to access the webinar. The PowerPoint slides and the webinar link can be found on our COCA webpage at emergency.cdc.gov/COCA. Again, that web address is emergency.cdc.gov/COCA. Continuing education is not offered for this webinar. After the presentation, there will be a Q&A session. You may submit questions at any time during the presentation through the Zoom webinar system by clicking the Q&A button at the bottom of your screen and then typing your question. Please do not ask a question using the chat button. Questions regarding the webinar should be entered using only the Q&A button. For those who have media questions, please contact CDC Media Relations at 404-639-3286 or send an email to media@cdc.gov. If you're a patient, please refer your questions to your healthcare provider. At the conclusion of the session, participants will be able to accomplish the following: provide e-cigarette and vaping terminology, summarize frequent clinical, laboratory, radiographic, and pathologic findings and outcome among cases, and discuss CDC recommendations for clinicians. I'd like to welcome our presenter, Lieutenant Commander Tara Jetlawi, to today's webinar. Lieutenant Commander Jetlawi is a medical epidemiologist at the Centers for Disease Control and Prevention. She's currently serving as the clinical team lead for the 2019 CDC Lung Injury Emergency Response. Lieutenant Commander Jetlawi graduated from New Jersey Medical School. She completed her MPH at the Rollins School of Public Health of Emory University in Epidemiology and obtained her bachelor's in engineering sciences from Dartmouth College. Lieutenant Commander Jetlawi, please begin.
Thank you. And good afternoon, everyone, and thank you for taking time out of your busy schedules to join us and learn about cases of lung injury associated with e-cigarette product use or vaping. For the next 30 minutes or so, I'd like to go through background information on this outbreak, provide a basic course in e-cigarette or vaping products, and then describe common clinical features of cases. Finally, we will review CDC recommendations and discuss the limitations and knowledge gaps at this point in time. As of September 17th, 530 cases of lung injury associated with the use of e-cigarette products or vaping have been reported to CDC from 38 states and 1 U.S. territory. 7 deaths have been confirmed among cases. Data are being updated weekly at the Outbreak website. To date, no specific etiology has been identified. All cases have reported using e-cigarettes or have reported vaping. From data reported in a recent case series, most patients have reported tetrahydrocannabinol or THC product use. Many have reported using both THC and nicotine, and some have reported using only nicotine. Other initial findings have been published in CDC's Morbidity and Mortality Weekly Report, or MMWR, and the New England Journal of Medicine. By nature of the case definition for this outbreak, all cases have reported use of e-cigarette products or vaping within 90 days of illness. According to recent publications, most patients seem to report symptoms within days of last vaping exposure, but some have been longer. As stated previously, data from publications describe that most have reported THC or CBD use, and some reported nicotine use alone. It is important to note that at this time, no single device type has been reported consistently, and no single e-cigarette or vaping product or substance has been reported consistently. This is the most current confirmed case definition. Please note that these case definitions are meant for surveillance and not clinical diagnosis. These case definitions are subject to change and will be updated as additional information becomes available. Cases have the following: a history of using e-cigarette products, vaping or dabbing, and pulmonary infiltrates on chest X-ray or ground glass opacities on chest computed tomography or CT, and absence of pulmonary infection, and no evidence in the medical record of alternative plausible diagnoses. For probable cases, reports include a history of using e-cigarettes or dabbing, and findings on chest imaging, and infection identified, but the clinical team caring for the patient does not believe infection is the sole cause of the underlying respiratory illness, or minimum criteria to rule out infection is not met or performed, and again, the clinical team does not believe infection is the sole etiology of illness, and no evidence of alternative plausible diagnoses are found in the medical record. The largest case series reported and published earlier this month described 53 cases from Illinois and Wisconsin, all with a history of e-cigarette product use. Of 41 cases who were extensively interviewed, 61% reported nicotine use, 80% reported THC use, and 7% reported CBD use. 37% reported THC use alone, and 17% reported nicotine use alone, while 44% reported using both products. Various brands and flavors have been reported. 94% of overall cases used e-cigarette products or vaped within 1 week before symptom onset, and 88% of cases reported daily use. I'll now move on to a basic course in e-cigarette or vaping products. E-cigarette products include devices, liquids, flavorings, refill pods, and cartridges. The actual devices heat liquid to produce an aerosol, which is then inhaled by the user. This aerosol may contain harmful substances such as those listed here. Devices vary in appearance and by manufacturer. Patients may use different terms to describe these devices, such as e-cigs, vapes, e-hookahs, vape pens, mods, tanks, and you may hear the term electronic nicotine delivery system, or ENDS. To the right, you see the different generational products going from first generation of disposable e-cigarettes, which look more like a regular cigarette, to second generation that have pre-filled pods, to the refillable tanks or mods of the third generation products, and finally, fourth generation mod pods or pre-filled mods, which may use nicotine salts. Liquid in the cartridge may contain the following: nicotine, THC, CBD, or butane hash oil, along with other components such as flavorings, propylene glycol, and vegetable glycerin. Liquid types may be either commercial refillable e-liquids, non-refillable e-liquid also purchased commercially, and homemade or street-sourced liquids. Some other useful terms are related to how these devices may be used. Hacking describes the modification of a device in a way that was not intended by the manufacturer. This could mean refilling a single-use cartridge with either homemade or illicit substances. Dripping is another way to hack a device, and means dropping liquid directly onto the device's heating coil to get higher concentrations of compound into the aerosol. Dabbing, on the other hand, means superheating a substance containing high concentrations of THC or other cannabis products. Let's now review frequent clinical features seen during this outbreak. Information from this section comes from both anecdotal and verified reports CDC has received from health departments. Formal and informal discussions have taken place between CDC, clinicians, and medical professional societies. Several publications this month in the MMWR, New England Journal of Medicine, contribute to the bulk findings. Most patients have been young and otherwise healthy, reporting a gradual onset of symptoms over the course of a few days to weeks. These include respiratory symptoms such as cough, chest pain, shortness of breath, gastrointestinal or GI symptoms, and constitutional symptoms such as fever, chills, fatigue, weight loss, or malaise. GI symptoms have preceded respiratory symptoms, and we have heard that these symptoms tend to resolve quickly after hospital admission, and evaluation for GI-related illnesses have not been revealing. While almost all cases have been hospitalized, many have had one or more evaluations prior to hospitalization in outpatient settings, such as urgent care. Upon presentation and hospital admission, patients have been noted to have fever, tachycardia, tachypnea, and decreased oxygen saturation on room air. This hypoxemia has been reported for one patient in the New England case series without any respiratory symptoms. Frequent lab findings include leukocytosis with neutrophil predominance, elevated inflammatory markers, and transient mild elevations in serum transaminases. Chest imaging, which is required for case definition, include either bilateral opacities on chest X-ray or ground glass opacities on chest CT. Abnormal findings may not be present on initial imaging, but may develop gradually. The only remarkable findings from CT abdomen pelvis have been from the cuts of lower lung fields. For many patients, initial therapies have focused on presumed infection, mostly antibiotics for community-acquired pneumonia, with or without steroids or observation. Many cases experience subacute or acute hypoxemic respiratory failure, requiring oxygen supplementation, which have ranged from nasal cannula to intubation and ventilation or extracorporeal membrane oxygenation, or ECMO. Patients who did not respond to antibiotics alone have tended to respond to steroids, either steroids alone or added on to antibiotics. When searching for an etiology, workup for infection has been completed without an identified cause, which is part of the definition of a confirmed case. Reports of pulmonary function testing, or PFTs, have been variable. Some patients have been evaluated with bronchoscopy and have had bronchoalveolar lavage or lung biopsy performed. Patients who did not have bronchoscopy may have been either too well or were considered for the procedure but were not stable enough. Routine and special evaluations of lung specimens have been performed. The New England Journal case series did report that 7 of 14 patients who had lipid staining with oil red O reported for BAL analysis had lipid-laden macrophages. It's very important to note that routine processing of tissues includes the application of alcohol, which removes lipids from tissue. Therefore, in order to test for lipids, lipid staining such as oil red O or Sudan black must be performed on fresh tissues and BAL fluid. The clinical and pathologic diagnoses that have been noted include findings consistent with acute lung injury or ARDS, such as diffuse alveolar damage. Diagnoses besides diffuse alveolar damage have also included lipoid pneumonia, acute necrotizing pneumonitis, organizing pneumonia, nonspecific inflammation, hypersensitivity pneumonitis, and eosinophilic pneumonia. Consultation with specialists have included pulmonary medicine, critical care, infectious disease, pathology, and toxicology. Despite the severity, most patients have survived to discharge. Again, most patients have been young and healthy prior to presentation. Some who did not return to pulmonary function baseline at the time of discharge did show improvement with post-discharge evaluation, while others still have had reduced pulmonary function, according to anecdotal reports. As of September 17th, 7 patients have died after being hospitalized. We'll now move on to CDC recommendations for clinicians. Current CDC recommendations are published in both the MMWR and a Health Advisory Network, or HAN alert, which can be found on the Outbreak website. As we learn more, CDC will provide updates as soon as possible. In the next slides, we'll review those recommendations. The first recommendation is simple, but we may not be doing it routinely. We need to ask patients specifically about e-cigarette product use or vaping. Depending on the patient's age or product use, this may be a sensitive topic. Depending on where you work, this may require educating additional staff or updating intake forms regarding social history. For those patients who report e-cigarette use or vaping within the last 90 days, ask about signs and symptoms of respiratory illness. Conversely, for patients who present with respiratory illness, ask about e-cigarette use or vaping. If you suspect e-cigarette product use as a possible etiology for your patient's symptoms, obtain a more detailed history regarding product use. This includes what substances have been used, THC, nicotine, CBD, or others, and what liquids have been used. How were those liquids obtained? Were they bought from a store? Were they mixed at home? Or were they bought off the street? What device has been used, and where were those purchased? Were they used as intended, or did any hacking occur? And did anyone else vape with the patient recently? In making a diagnosis, remember that the case definition is for surveillance purposes and is not intended for diagnosis. Consider all possible causes of illness depending on patient symptoms and signs on physical exam. Depending on the severity of presentation, consultation may be indicated. While lipoid pneumonia has been associated with inhaling the lipids in aerosol from e-cigarettes or vaping, the decision to perform BAL with or without bronchoscopy should be based on the individual clinical picture. Remember that not all BAL specimens that have been reported with lipid staining among cases have noted lipid-laden macrophages. Similar to BAL specimen, lung biopsies have been performed on some patients, and the decision to perform the procedure should be based on the individual clinical case. If biopsy is performed, consider lipid staining. CDC has guidance on the provider outbreak webpage with the link at the bottom of this slide and at the end of our slides regarding lipid staining. Before performing, consider consultation with specialists to inform your evaluation. Whether or not lipid staining is performed or possible at your institution, routine processing and histopathology is still important and valuable to the evaluation. Contact your state or local public health officials for assistance with testing, retaining specimens, and storage if desired. For management of these patients, decisions should be made based on the individual clinical case. This pertains to the decision to admit to the hospital, initial evaluation and treatment, and decision to consult with specialists. Clinical improvement has been reported with the use of steroids. Dosing, route of administration, duration, and timing have varied for both inpatient and outpatient management. Again, the decision to administer steroids should be made on case-by-case basis, considering the likelihood of other etiologies. Follow-up evaluation may be considered as clinically indicated depending on the severity of the disease. As mentioned, CDC has guidance for evaluation of pathologic specimens, with the link again here at the bottom, and a PDF can be found on CDC's provider page for this outbreak. CDC is accepting lung tissue for evaluation through CDC's Infectious Disease Pathology branch. If possible, submission of formalin-fixed or wet lung tissue is encouraged in order to perform lipid staining using osmium tetroxide. This must occur before routine tissue processing and paraffin embedding. This lab will also review tissue histopathology and perform additional testing as indicated. If you have lung tissue for evaluation for a case of lung injury associated with e-cigarette product use or vaping, please first report the case to your state or local health department. Pre-approval is required before submitting tissue specimens to CDC, and the contact email for pre-approval are listed here. In the unfortunate event of a fatality, autopsy can be considered, and recommendations for autopsy can be found within CDC guidance on the provider webpage. Again, fresh lung tissue for lipid staining prior to processing should be considered, along with routine histopathology. Infectious disease testing should also be considered depending on the patient's history, clinical course, or any additional autopsy findings. Regardless of the ongoing investigation, please note the following. E-cigarettes should not be used by youth, young adults, pregnant women, or adults who do not currently use tobacco products. Anyone who uses e-cigarette products should not buy products off the street, should not modify products or substances at home in a way that was not intended by the manufacturer. Tell your patients who use these products to monitor themselves for symptoms such as cough, shortness of breath, chest pain, abdominal pain, nausea, vomiting, or diarrhea, and to seek medical attention if they're having any symptoms. For those trying to quit tobacco products, including e-cigarettes, there are evidence-based treatments, including counseling and FDA-approved medications. There are links to resources for more information on our webpage. If your patients are concerned about these specific health risks seen in this outbreak, please tell them to consider reframing from using e-cigarettes or vaping products. If they are using these products to quit cigarette smoking, they should not return to smoking cigarettes. If patients continue using e-cigarette products, as stated before, tell them to monitor for symptoms and seek care with any concerns. Patients and providers can find their local poison control center at this 1-800 number. Any detailed reports of e-cigarette related health or product issues can also be reported to the FDA via their online safety reporting portal at this link. In order to inform this investigation and know what is causing it, we need your help in reporting cases. If there are any remaining products, the actual device, or e-liquid, please coordinate with your state or local health department for testing. As we learn more, CDC will provide updates as soon as information is available. So please visit the CDC website for updates and additional resources. Finally, I'll spend the last few slides reviewing our limitations and knowledge gaps. Information that we have so far includes small published case series compared with the number of cases that have been reported to this point. We also have anecdotal data to generate some hypotheses. As mentioned, the case definitions for outbreak surveillance is not intended for diagnosis or to guide clinical decisions. As of yet, there's no diagnostic criteria that exist, and as we have discussed, there have been a multitude of histopathologic findings. Most cases have been severe and hospitalized, but the true spectrum of this illness could be unrecognized. Investigations at the state level have been ongoing, and national efforts have been underway since mid-August. CDC is updating the website regularly as data come in and analyses continue. Beyond published case series, there are no systematic data for exposure or additional clinical information. The available data do not suggest a purely infectious etiology, but there may be concurrent processes in play. There are no decision-making tools to distinguish infection versus non-infection at presentation, so it's important to rule out and empirically treat infectious etiologies as appropriate, even in patients with exposure history. Patterns of illness could also change with the approaching respiratory viral season. Furthermore, it remains unclear whether this is a new syndrome or a newly recognized syndrome previously thought to be a pneumonia or a pneumonitis of unclear etiology. The long-term prognosis of lung injury associated with e-cigarette use or vaping is not yet known. Age-related differences have not yet been assessed. We do know the outbreak has predominantly affected younger patients, and updated information is now available on the CDC website. However, defining a case among adults with chronic lung disease or other comorbidities may be more difficult, leading to underreporting. It is still unclear whether adults who have more severe illness are more likely to result in death. Lipoid pneumonia has been reported, but as mentioned, diagnoses have been heterogeneous. Questions still remain, such as whether lipid-laden macrophages are markers of disease or of exposure. BAL has not been obtained universally on bronchoscope evaluation, and in turn, nor has lipid staining, which is a non-routine procedure, so the frequency of this finding is unclear. Characteristics of the cellularity of BAL fluid are uncertain because they could be altered by antibiotics or steroids and influenced by the timing of these therapies and interventions. Autopsy has not been performed for all cases resulting in death, and the results from those have not been reported for all cases when they've been performed. To summarize, This investigation has yet to identify any specific substance or product linked to all cases. Most patients have reported using THC or CBD, and some have reported nicotine use alone. Most patients have been hospitalized with respiratory illness and received treatment for presumed infectious etiologies. Some have responded to steroids with or without antibiotics. Please report cases to and coordinate product testing with your local or state health department. CDC will provide updates with information as it becomes available. The link to our healthcare provider website for this outbreak is found here. This slide deck will be available on our website in the next few days for anyone who wishes to share or give additional talks. We will be updating the website with information, resources, and recommendations as we learn more. Thank you again for joining us. We can now take your questions.
Thank you so much, Lieutenant Commander Jatlavi, for providing our audience with such a wealth of information on this important emerging public health challenge. We appreciate your time and value your clinical insights on this matter. We will now begin our Q&A session. Joining us today for the Q&A session from the clinical team of CDC's 2019 Lung Injury Emergency Response will be Commander Malika Glover, Dr. Sarah Reagan-Steiner, Dr. David Wiseman, and Dr. Ahmed Jamal. Please remember, you may submit questions through the webinar system by clicking the Q&A button at the bottom of your screen and then typing your question. Again, please do not ask a question using the chat button. Our first question is regarding the specific products. The question asks, are there any specific products that clinicians should inform their patients to avoid?
This is Tara Jatlawi. Thank you for that question. Our investigation is ongoing, and as we stated, we have not identified any specific products. So that includes devices, liquids, pods, or substances that are linked to all cases. Most patients have reported a history of using e-cigarette products containing THC, but there are many patients that have reported using THC and nicotine, and some that have reported the use of nicotine alone. Thus far, illnesses involving products containing THC have been primarily associated with liquid-based e-cigarette devices. These devices are sometimes called mods, vape pens, vapes, and tank systems. If you are concerned about these specific health risks, CDC recommends that you tell your patients to refrain from using e-cigarette or vaping products. CDC further recommends if someone as an adult who used e-cigarettes containing nicotine to quit cigarette smoking, they do not return to smoking cigarettes. If people have recently used an e-cigarette or vaping product and have symptoms like these reported, they can see a healthcare provider. And please remind patients to not purchase illicit products or substances off the street or modify products in a way not intended by the manufacturer.
Thank you for that. Our next question follows a theme. We have multiple questions on this topic, and these are providers that would like to know that if they're at a local public health department and their patients bring samples or leftover vaping product, what they should do with that if they need to be sent for testing. Is that within the purview of CDC or the Food and Drug Administration?
Can you, I'm guessing to clarify the question, if there are samples, then my suggestion would be for a provider to contact their local or state health department in order to coordinate testing. That testing is being performed through the FDA.
Thank you for that. Our next question is regarding, are you aware of cases that might be mild that are taking place where patients are not reporting to the hospital?
This is Tara Jatlawi again. Reported cases may have been ascertained from various data sources, and we know that we have seen patients in both the inpatient and outpatient facilities. So if you as a provider, if you think your patient may have lung injury associated with either e-cigarette product use or vaping, please report the case to your state or local health department, regardless of your clinical setting.
Thank you. Another question we have is a clinician writing in to ask for an explanation on the age distribution, if there's any idea why the age distribution is as it is.
Thank you for that question. We're just starting to understand more about the patient population that have been affected by this illness, but we don't at this time understand why certain populations may be more affected than others, how it may be related to the incidence of the exposure in certain populations may be of importance, but that's still something that's under investigation.
Thank you. If a provider was to see a patient that is reporting with respiratory illness and reports having recently used vaping, what should the provider do?
This is Tara Jotlowy. Patients should be evaluated and treated for other possible causes of illnesses as clinically indicated. So approach the patient as you would in any other manner as far as doing testing or evaluation or treatment. Depending on the severity, you can consider consultation with specialists such as pulmonary specialists, infectious disease, critical care, and medical toxicology, and also consider close follow-up as indicated by the individual case presentation.
Thank you. Our next question asks if the problem with oil inhalation is specific to a certain oil, or is it likely to be a factor from multiple types?
This is Tara Jotlowy. That's still under investigation. We haven't been able to link any particular specific product, whether that's substance, diluent, or any other device that may be contributing to these illnesses. So we don't have further information on a consistent exposure that may be causing these.
Thank you. There are a few questions that would like you to reiterate the use of steroids in treating patients and managing their treatment. When are they appropriate and how should they be used?
So we do know that clinical improvement of patients with lung injury associated with e-cigarettes has been reported with the use of corticosteroids. However, the decision to use steroids should be made, again, on a case-by-case basis based on the risks and benefits and the likelihood of other etiologies. Currently, we do not have sufficient information to recommend any specific steroid dosing or administration for either inpatient or outpatient care.
Thank you. Can you please address the occurrence of any, if present, GI symptoms associated with these cases?
This is Tara Jotlowy again. Yes, we do know that according to the 53 patients in the case series from Wisconsin and Illinois, GI symptoms, any GI symptom occurred in just over 80% of patients. The most common symptom was nausea, with about 70% of those patients reporting nausea. closely followed behind with vomiting in 66%, and then some had diarrhea and abdominal pain. Generally, what we have heard is that the GI symptoms tend to resolve after admission or shortly after, before the onset of any more severe respiratory findings, and that workup for any GI illnesses have been inconclusive or have been negative.
Thank you. Our next inquirer asks if there are any recommendations you have for clinicians that might be seeing patients as far as how they should screen for use of vaping devices.
So our recommendations, and I guess just going to just basic history taking, is to include e-cigarette or vaping history within your normal intake of taking a patient's history. So asking about what products they are using, if they have any recent history of vaping. And in particular, if you have a patient who has any symptoms of respiratory illness, specifically ask about e-cigarette product use or vaping within the last 90 days. And if that's present, I would pursue additional questioning that we have laid out in these slides, and then also in our Health Advisory Network alert that went out at the beginning of September, which lists out what specific questions around substances used, sources, devices, where products were purchased, how the device was used, whether aerosolization, dabbing, or dripping, and then any potential sharing with other people.
Thank you. Our next question asks, are we aware of symptom onset after initial imaging? How long does the symptom onset take? And does the initial chest imaging show the findings?
We know that patients have had an onset of various symptoms over days to weeks. However, the timing and the actual course of illness, we don't have as clear of a picture. So from when the initial onset of maybe symptoms to presentation to imaging findings to worsening disease is still unclear or may be varied.
Thank you for that. Our next question inquires about what percentage or number of total cases used commercial products versus either homemade, hacked, or otherwise altered products?
We don't have information based on reported cases to CDC for specific product use or type at this time.
Thank you. Our next question asks, are you aware of any cases such as this outside the United States?
To our knowledge, I'm sorry, this is Tara Jotlowy. To our knowledge, there are no concurrent outbreaks of lung injury associated with e-cigarette products or vaping in other countries, although there may have been cases reported.
And this is David Westman. There was a report in the general media today about a case in Ontario, but we don't have any specific knowledge of that.
Thank you. We have received a couple of questions regarding biopsies and tissues and pathology. Can you please elaborate on when a patient needs a lung biopsy, and then what is the procedure for the clinician to send pathology samples to specimens to CDC?
Hello, this is Dr. Sarah Reagan-Steiner. So lung biopsy is an invasive procedure. The decision to perform a lung biopsy is at the discretion of the clinical team and should include consultation with pulmonary, critical care, and other specialties. Lung biopsies have been performed on some patients. If a biopsy is performed, lipid staining can be performed and is best to be performed on fresh tissues. because routine tissue processing of formalin-fixed tissues involves applying alcohols, which remove lipids prior to paraffin embedding. So please consider consultation with specialists in pulmonary medicine and pathology to help inform any evaluation plan. The roles and frequencies of different biopsy methods performed on patients as part of this outbreak are not known at this time. If there is interest in submitting pathology or tissue specimens to CDC, please first report any possible cases of lung injury associated with e-cigarette product use or vaping to your state or local health department. And pre-approval is required to submit any tissue specimens to CDC. Information, including email addresses for how to obtain pre-approval, is on the resources provided.
Thank you. Our next question is a theme of sorts that we have received regarding vitamin E acetate's role in these cases. Can you please elaborate on the role vitamin E acetate has to play in these cases?
This is Tara Jotlowy. So we don't yet know the specific cause of these lung injuries. The investigation has not identified any specific e-cigarette or vaping product, so devices, liquids, refill pods, and cartridges, brand, or substance that has been linked to all the cases.
Thank you. Have there been any renal abnormalities reported as well in these patients, and can you please address that?
From either the published information or anecdotal reports and conversations that we've had with clinicians, we've only seen one case of acute kidney injury in a patient from the Illinois and Wisconsin case series, but otherwise we haven't heard of any renal disease associated with this outbreak.
Thank you for that. Our next question asks about empiric antibiotic use. Which antibiotic or antibiotics would you recommend?
The recommendations for antibiotics shouldn't change. It should be according to the patient's, the population that you're seeing, and the individual case presentation that you're evaluating. The evaluation and the treatment of patients should not change based on any exposure to e-cigarette or vaping.
Thank you. Our next question is regarding a clinician who's asking that they're aware of patients that sometimes report using both cigarettes in tandem with vaping products. Is there any suggestion of exaggerated injury or augmented harm?
At this time, we don't have that information yet. Similar to the fact that we don't have any singular source that we've identified being linked to all of these cases, or even a majority of cases, we don't understand yet the relationship between those who may smoke cigarettes and use e-cigarettes or vape at the same time.
Thank you. Our next question is sort of a theme as well. It seems to be a popular concern. And the question is there any evidence to show that there is long-term injury associated, or is it too early to tell?
It seems to be too early to tell. We have spoken to some clinicians who are following patients who have more of an ARDS type picture and following them up with pulmonary function tests. And there have been anecdotal reports of some patients returning to normal, some patients that still have reduced pulmonary function, but we don't have enough information to give a full and clear picture as to what prognosis may be. We haven't been able to examine these patients for long enough to give a clear answer to that.
And this is David Weissman. The lung function test that we anecdotally told is the one that's most has been carbon monoxide diffusing capacity.
Thank you. I'm going to move on to the next question. Our next question is regarding comorbidities or pre-existing conditions. Have any of these patients presented with respiratory comorbidities or pre-existing conditions?
This is Tara Jotlouis. In the case series from Illinois and Wisconsin of the 53 patients that were included in that publication, about 30% of them had asthma, but there was otherwise no underlying chronic lung disease process. And we have heard the same, that there's been some pulmonary comorbidities like asthma, but we haven't been hearing that any other pulmonary diseases frequently. But that's not something that that we're at this time we have enough information to say.
Our next question is about presentation, and the question essentially asks, what are some of the initial presentations or symptoms to look out for when assessing patients?
This is Tara Jotlouis again. Patients have had an onset of various symptoms. Some have been over days and some have lasted weeks. Those have primarily been respiratory symptoms such as cough, chest pain, shortness of breath. Some have had hemoptysis. GI symptoms, as mentioned, abdominal pain, nausea, vomiting, diarrhea, and there's also been some constitutional symptoms like fatigue, fever, weight loss, malaise that have been reported. And as we mentioned during the presentation, the GI symptoms have sometimes preceded respiratory symptoms, and again, a lot of patients have sought initial care in ambulatory settings, some with a few visits before presenting and being admitted to the hospital.
Thank you very much. And we have time for one last question. And the question is, can you elaborate a little bit more on the phenomena of lipoid pneumonia and what are the best ways to test for it?
This is Tara Jotlouis. Lipoid pneumonia is a rare condition where fat enters the lungs either exogenously from outside factors or endogenously. So it's been associated with inhalation of lipids and aerosols generated by either e-cigarette products or vaping, and it's been reported in some cases based on the detection of these lipid-laden alveolar macrophages obtained on BAL. Lipid staining can be performed, including oil red O or Sudan black, in order to see these lipid-laden macrophages. The decision about whether to perform a BAL in order to find the lipid-laden macrophages should be based on individual clinical circumstances. Lipoid pneumonia can also be identified with lung biopsy by identifying lipid-laden macrophages by lipid staining performed on fresh tissues, as well as routine histopathologic evaluation of regular processed formalin-fixed paraffin-embedded tissues.
Thank you very much. On behalf of COCA, I would like to thank everyone for joining us today, with a special thank you to our presenter, Lieutenant Commander Tara Jotlouis, and to Commander Malika Glover, Dr. Sarah Reagan-Steiner, Dr. David Weissman, and Dr. Ahmed Jamal for joining us for the Q&A session. The recording of this call will be posted within the next few days to the COCA website and available on demand at emergency.cdc.gov/COCA. Again, the web address is emergency.cdc.gov/COCA. Please join us for our next COCA Call that will be held 1 week from today on Thursday, September 26 at 2 p.m. Eastern Time, where the topic will be the 2019-2020 Recommendations for Influenza Prevention and Treatment for Children, an update for pediatric providers. To receive information on upcoming COCA calls or other COCA products and services, join the COCA mailing list by visiting the COCA webpage at emergency.cdc.gov/COCA and click on the Join the COCA mailing list link. To stay connected to the latest news from COCA, be sure to like and follow us on Facebook at facebook.com/CDC Clinician Outreach and Communication Activity. Again, thank you for joining us for today's call. Have a great day.